Med-Surg chapters are about 50 pages long, and half of the time you can tell what is important. Before we get into the details, I always like to zoom out first to look at the big picture of the chapter. I use a concept map like these to break it down heavy chapters. Chapter 53, Coordinating Care for Patients with Musculoskeletal Disorders. Here is my concept map. This chapter has actually 7 disorders. It starts with introduction, and the second is muscular dystrophies. Then 3, it's osteoporosis. 4, Paget disease. 5, it's osteomyelitis, scoliosis, joint replacement, and then lastly it's bone cancer. And this is the way the book categorizes the chapter, and each of them, like here the disorders, there are 7. All of them, they have epidemiology, patho, clinical manifestation, and interprofessional management. I'm going to go one by one, and also I have some pictures to show, just to kind of make it simple and easy to understand. So musculoskeletal disorders are a broad category of conditions that affect the bones, muscles, and joints, leading to impaired mobility and reduced quality of life. This chapter covers several key disorders, including muscular dystrophies, osteoporosis, Paget diseases, osteomyelitis, scoliosis, joint replacement, and bone cancer. The primary focus is on understanding the pathophysiology, clinical manifestation, and interprofessional management of those conditions to provide comprehensive patient care. Each condition presents unique challenges, from progressive muscle degeneration to chronic bone pain and increased fracture risk. Muscle weakness, bone disorders increase infection risk and impact IDLs. Musculoskeletal disorder impact our ability to move and thus affect our ability to perform activities on daily living. Weakness, pain, or infection affects our movement and or bone strength, at times limiting our ability to muscular dystrophies. Pathophysiology, we know that Duchenne, DMD, well-known form, most common in children, males between 5 and 24 years old. Genetic component caused by new genetic mutation. Becker, primarily prevalent in males, typical occurs in childhood. So myotonic dystrophy, most common form of MD. Adults inherit X chromosome, link only known associated risk factor. So the caused by mutation to dystrophin gene, dystrophin protein responsible for muscle repair, located on plasma membrane of muscle fibers, and provide reinforcement stabilization of glycoprotein complex. Absence or reduction of dystrophin glycoprotein complex digested by proteosis, which causes degeneration of muscle fibers resulting in muscle weakness. Primary comorbidities: progressive muscle weakness, muscle wasting, increased muscle enzyme serum levels, keratin kinase or CK. We have interprofessional management focused on symptomatic treatment, physical therapy to maintain mobility and respiratory support as the disease progresses. And clinical manifestation is 9 groups, all presenting progressive muscle weakness, all typical present with chronic pain in lower back legs, progressive deterioration, weakness to facial, limb, respiratory, and cardiac muscle, and ultimate result in muscular damage. Muscle bulk is reduced, resulting in fat and excessive scar tissue. Falls put patient at risk for fracture, progressive deterioration of facial muscle associated with problems with dental hygiene, speech clarity, and articulation. Most life-threatening results in cardiopulmonary compromise as result of development of cardiomyopathy. So results in arrhythmia, short of breath, and extreme fatigue. We have labs, medical management diagnosis, usually begins with preliminary review of serum muscle enzymes such as CK. Then we have chest X-ray, EKG, ACG, CT scan, and electromyography frequently warrant to determine extent of muscle wasting, presence of cardiopulmonary compromise. Definitive diagnostics, difficult secondary to the fact that clinical presentation for all MDs are preliminary in nature. So the gold standard, the muscle biopsy, biopsy, small piece of muscle tissue extracted and examined for changes in structures of muscle cells. So the diagnostics criteria now incorporate genetic testing. We have treatment which we focus on. It's no specific cure. It's mostly pharmacological intervention, glucocorticoid therapy, frequent medication of choice in conjunction with supportive collaborative care. So includes use of supplements like coenzyme Q10, carnitine, amino acids, and anti-inflammatory meds and antioxidants. Pain management primarily done with Tylenol, aspirin, or ibuprofen. Psychosocial management more complicated and extensive. So let's show some pictures. So here it's prevent falls, mobility support, complication, spinal deformity. Later on we talk about scoliosis as well. So let's go for some pictures. So we need to do the supportive service and genetic causal information is medically recommended. Complication, severe complications, spinal deformity, and neuromuscular deterioration causing weakness of trunk and uh, lower extremities, scoliosis, and overall thoracic lumbar changes, respiratory and cardiac compromise can develop. Osteoporosis is a chronic condition characterized by deterioration of bone tissue and density, significantly increasing the risk of fracture. So, chronic condition that results in deterioration of bone tissue density, increased risk for fracture, high risk for fracture, Caucasian small framed woman with low body weight. So the risk factors defined as primary and secondary. Primary risk factors are genetics, age, race, gender, family history, smaller body frame, age older than 50, postmenopausal, gender females more than males, race Caucasian, smaller body frame around 50 less than 58 kilograms. Secondary risk factor, meds, corticosteroid therapy, more than 3 months, anticonvulsants, heparin therapy, thyroid hormones, disease like Cushing's, rheumatic arthritis, hyperthyroidism, hyperparathyroidism, chronic liver disease, irritable bowel disease, nutrition, low in calcium intake, low vitamin D intake, inadequate calories, high K intake, high alcohol consumption, lifestyle, secondary lifestyle, cigarette smoking, excessive alcohol consumption, previous fractures. So other can be parental history of hip fracture, recurrent falls, prolonged immobilization. So we know the patho is like bone, living, growing tissue, right? And bone remodeling constantly forms new bone while replacing the older bone. Two types of bone cells, osteoclasts and osteoblasts. Osteopenia, it's a bone loss. Bone mineral density peaks between 20 and 30 years old. Bone remodeling altered, altered related to aging and other risk factors. Important risk factor related to aging: decreased calcitonin, decreased estrogen levels, increased parathyroid hormone. Clinical manifestation: patient not diagnosed until fracture occurs after unremarkable fall strain. We have fragile fracture most occur in spine, hip, and distal radius. Medical management, diagnosis, treatment, meds, complication. Medical management, the universal recommendation is annual weight measurements with preferred wall-mounted stadiometer. Gold standard for BMD measurements for women over 65 years old, men over 70. Postmenopausal women, men between 50 and 69 with high risk factor profile. Dual energy X-ray absorptiometry DEXA scan gives precise measurement at clinical relevant skeletal points with body within body, which highlights area for fracture. Medical management, the treatment focus on prevention and early screening, comprehensive approach to management, weight loss and muscle strengthening, exercise to reduce incidence of falls and fracture, highly recommended. Healthy lifestyle that includes weight-bearing exercise that helps build and maintain strong bones, avoidance of smoking and exercise alcohol intake, medical management, medication intervention focused on preventing and slow progression of bone loss, first line of prevention, safe and inexpensive with use of calcium and vitamin D. Also, we have higher doses of calcium shown to have limited benefit and related higher incidence of development of kidney stones, and then the sunlight for 15 minutes a day helps with vitamin D and calcium absorption. So we have like a few meds here, bisphosphonates impedes bone reabsorption and inhibiting osteoclast activity. My light. I have this in NCLEX, the part 3 on the video, like previous chapter, in this chapter, more about this. So we have the fall prevention, diet education. Now I'm going to show you some pictures. As you see here, normal bone looks very pretty and dense. Here a lot of big holes, and this hole is full of air, so imagine it's very thin. Osteoporosis, low bone density. So here compression factor can be even in the bone here, not necessarily in the spine. So moving next. Paget disease of bone, PDB. Paget disease is a bone metabolism disorder involving accelerated disorganized bone remodeling. We have this process. This process is driven by increase in size and number of osteoclasts, which leads to increased bone reabsorption followed by an increased rate of new bone formation by osteoblasts. And the resulting bony structure are enlarged, weak, and prone to deformities and fracture, particularly in the skull, femur, tibia, and vertebra. So this is not a cure. So let's talk more about pathophysiology, also referred as osteitis deformans, bone metabolism disorder associated with accelerated bone remodeling resulting in bone that is structurally abnormal. Skeletal areas most affected, we know, skull, femur, tibia, pelvic bones, and vertebral columns. Confirmed diagnosing not known until fracture develops or occur. Bone constantly renewed through the process of remodeling, maintained by two types of bone cells, osteoclast and osteoblast. So let's review what is osteoclast: increase in size and number, escalating reabsorption of bone. Osteoblast add the new bone at an increased rate, which leads to enlarged bony structures that are uh, disorganized in structure and reduced in mechanical strength, leading to a risk for development of deformities and fractures. Clinical manifestation initially asymptomatic. As it progresses, varies according to severity, extent, and site of bony involvement. Two main clinical characteristics: pain, deformity. Fracture, bone tumors, neurological disease, and cardiac disease related to dysfunction with calcium and phosphate imbalance. A typical manifestation: increase in pain with weight bearing, increase in nocturnal pain. Um, so we have the labs: test, X-ray, bone scan. Um, so we have made incidentally via radiological exam or routine lab chemistry screening that reveals an increase in serum alkaline phosphate. Specific indicators to focus on: previous fracture, deformities, pain, or family history. So comprehensive history and physical exam with measurements of serum concentration of alkaline uh, phosphatase, calcium, and urine hydroxyproline excretion. Medical management: medication requires clinical appropriate antibiotic therapy, surgical debridement, incision or infected and or necrotic tissue bone. What else? Again, we have the same medication here, pain meds. Um, So nutrition support focus on high protein diet to support and aid in wound healing. Opioid analgesia indicate to manage pain. Antibiotic regime is based on culture and severity results. Surgical management focus on secondary degenerative changes of bony structure causing osteoarthritis. Can span from joint replacement to spinal decomposition and stabilization. We have a primary goal: reduction of pain. Um, we need to monitor for deformities, fall risk, um, and pain. Here are how it looks like. This picture I put in the key terms video, but kinda it cut me off because this is kinda square, not landscape. So you see here the normal bone, and here it's the pagetic bone. See deformity here. Okay. Osteomyelitis. Osteomyelitis is a serious infection of the bone that can be either hematogenous, spread through the bloodstream, or non-hematogenous, resulting from direct trauma or an open fracture. Osteomyelitis is a bone infection caused by bacteria or fungi that can spread through the bloodstream or form a nearby injury or surgery. Clinical manifestations include localized pain not relieved by rest, swelling, tenderness, erythema, warmth, fever, and malaise. Chronic osteomyelitis presents with persistent bone pain and localized swelling and warmth. Symptoms include, of course, bone pain, fever, chills, swelling, and redness. And it's treated with antibiotics and possibly surgery to remove infected tissue. The priority in nursing diagnostics is infection. The initial treatment involves, of course, a course of IV antibiotic and may require surgical debridement. Opioids and analgesics are often used for pain management. Bone infection, labs, increase in white blood cells, CRP, ESR, test bone biopsy, MRI, then meds. We have intravenous antibiotics, opioids for pain. Nursing, we have wound care, monitor for sepsis. I'm going to show you some pictures, and here you see how this looks in the X-ray. My light, like here looks in the X-ray, and this is inside the bone. You see here but also on the skin, it's just like puffy red, and as you touch, it feels like very sore and pain. And most of people thinks that it's the muscle itself, but actually it's the bone. And also dogs can have this as well, so not just human. Okay, or maybe cats too. Okay. Scoliosis. So scoliosis is a spinal curvature greater than 10 degrees. They call it Cobb's angle, often accompanied by rotation and compression. So conservative treatment for mild to moderate cases include physical therapy, exercise, and pain management. The epidemiology prevalence affects like 2 to 3% of the United States population, approximative like 6 to 9 million people. Demographics, adolescents, idiopathic scoliosis, ages between 10 and 15, affects 2 to 3%. Girls have slightly higher incidence. Incidence of lumbar scoliosis rises in adults over 40. So risk factors: smoking, obesity, older age, sedentary life, heavy physical work, and lower educational level. Pathophysiology, it's structural alternation characterized by spinal curvature of greater than 10 degrees Cobb's angle, normally associated with rotation and compression. Categories can be neuromuscular, associated with conditions like cerebral palsy or muscular dystrophy. Congenital asymmetry due to congenital anomalies. Idiopathic, it's no distinct etiology defined by exclusion. Progression, it's more than 50 degrees. So when it's more than 50 degrees curvature, causes instability with the spinal column. More than 60-degree curvature causes significant compromise to the thoracic region, leading to cardiopulmonary compromise. So here might be a surgical for this. Clinical manifestation, sideways curvature of the spine, so that more than 10 degrees, asymmetry, uneven shoulders, uneven waist, or one hip higher than the other. Prominence of the one shoulder blade or thoracic rib region. Leg length discrepancy. Pain typically in the thoracic and or lumbar region, often due to degenerative changes. Severe causes, signs of cardiopulmonary compromise like tachypnea, tachycardia, short of breath, decreased saturation O2. Next, we have the diagnostic and labs. Cobb's angle, the standard measurement of quantity curvature, intersection of perpendicular lines from the most affected upper and lower vertebrae. Visual inspection, assessment of asymmetry in shoulders, scapulae, and hips. Adams forward bend test. Patient bends forward until the spine is parallel to the floor to reveal thoracic or lumbar prominence. Radiography, X-ray to confirm diagnostic severity and skeletal maturity. Scoliometer, from scoliosis, scoliometer, used to quantify track rotation. Labs. Note the textbook doesn't list specific laboratory test for diagnosis scoliosis itself. Diagnosis is primarily based on physical exam and radiographic imaging. For the lab, also we can think about CBC to see more there about calcium and vitamin D. But moving forward, nursing management assessments, we go with vital signs, monitor for tachypnea, tachycardia, and low oxygen saturation, signs of cardiopulmonary compromise, pain, assessed frequently as it often accompanies the disorders or indicates progression. Safety, assess for balance and gait, disturbance that increase fall risk. Nursing action, pain management, administer medication ranging from aspirin, NSAIDs, mild to moderate, up to opioids for severe. Thermal therapy, apply hot and cold therapy to reduce pain and promote flexibility. Orthotics, assist with maintenance of total contact orthotic, so TOC, TCO, or thoracic lumbar spinal orthotic. Braces used for stabilization. Patient teaching. Brace care, teach patient or family that the brace is typically worn at all times unless prescribed otherwise, and they might need help with dressing or skin care. Medication safety, educate on the risk of opioids, addiction, respiratory depression, and constipation. Activity, encourage prescribe exercise. What else? The weight reduction to prevent disease progression. Instruct to report any falls immediately due to risk for subluxation or hardware failure. So for education, proper base wear, exercise, weight, safety for fall prevention. And now I'm going to show you this picture. I found these two pictures online. You can see this, the S, here the thoracic area is towards to lumbar area. So this abnormal, you can feel it an S here. See how severity will go, and here is the lumbar, and this is the double. Okay. Total joint replacement is a surgical procedure to replace a damaged joint, most commonly the hip or knee. It is often indicated for patients with severe osteoarthritis that has not responded to conservative treatments like exercise and analgesics. The procedure aims to relieve pain and to restore function in joints affected by degenerative condition. Preoperative and postoperative nursing care is very critical and includes patient teaching, pain management, and monitoring for potential complications such as infection, DVT, which is vein thrombosis, deep vein thrombosis, and dislocation of the new joint. Hip or knee replacements cause the osteoarthritis. Test X-ray, nursing, post-op, mobility, infection prevention. So epidemiology and pathophysiology, prevalence most common in hips and knees due to osteoarthritis, cause cartilage erosion, bone sutures and narrowing. Procedure, damage joint, replaced with prosthetic, cold chrome polyethylene. Lifespan is like 10 to 15 years. Clinical manifestation and diagnostic, so signs and symptoms is like pain, functional deformities, stiffness, crepitus, leg length discrepancy on the hip. Imaging, it's X-ray that confirm narrow space, and MRI for more cartilage and how ligaments and how in that joint looks like. So we have pre-op labs, CBC, hemocrit, hemoglobin for blood loss risk, coagulation studies, ACG. Medication, of course, we have the NSAIDs, opioids. Usually they use the PCA. A patient needs to be taught how to use that. Safety, anticoagulants offering for the DVT prevention and antibiotics for prophylaxis. Nursing management, assessment, neuro, also the neurovascular, the 5 Ps, virals, hypovolemia, wound drain infection, intervention, early ambulation. So within 6 hours needs to start for ambulation, DVT. Then we have adoption pillow, avoid flexion of 90 degrees. So again, education for hip precaution, no corrosion leg, fall safety, remove rugs, make sure that the floor is all clean and clear and no furniture around. Bleeding precaution, anticoagulant safety, bleeding precaution, soft toothbrush, electric razor, dietary restriction, vitamin K, because due to warfarin. And now I'll show you the picture. Again, there are two pictures. So here it's for the knee, and here it's for the hip. So here is the corrosion, and how pretty they make it, like so perfect here. And that's it for the total joint replacement. On bone cancer, I'm gonna spend a little bit longer here. So it's specifically focusing on osteosarcoma. So osteo, it's the bone cancer. So that's why bone cancer. Osteo, it's bone, and sarcoma, it's the cancer, as highlighted in our textbook. And epidemiology, so the prevalence is rare, like less than 1% of all cancers, but it's still around 3,910 new cases annually in the United States. The demographics, osteosarcoma is the most common primary malignant tumors in adults, though it peaks in adolescents ages 10 to 30, and older adults linked to Paget's disease. Gender affects males twice as often as females. Risk factors: prior radiation, chemotherapy, Paget's disease begin bone lesion, and genetic syndrome like Lee found many. And then the pathophysiology origin can be primary, starts in bone, like osteosarcoma, obviously, or secondary, metastasis from breast, lung, kidney, etc. Mechanism: rapid abnormal bone growth triggered by an oncogenic agent, involves the production of osteoid, immature malignant bone cells, and disruption of normal osteoblast, osteolytic activity. Common sites: rapidly growing bone areas, distal femur, proximal tibia, and proximal humerus. What else? Clinical manifestation includes pain, redness, warmth, and deformity around the tumor site. Pain is localized, worsened with motion, unrelieved by rest, and often present at night. So this is like a very well-known pain at night. It's like a signature. Local signs, it's swelling, soft tissue mass, large tender, redness and warmth at the site. Functional, decreased range of motion, limping. Fractures, pathological fracture, bones breaks without significant trauma due to weakness. The diagnostics and tests and labs, we have imagings, X-ray, CT, initial visualization, MRI superior for defining soft tissue involvement and neurovascular compromise. Bone scan detects hot spot of increased activity. Biopsy is the gold standard definitive test to determine the cell histology and the stage. Labs, we have labs here, elevated alkaline phosphatase, the ALP, lactate dehydrogenase, the LDE, the ESR markers of bone tumors inflammation. The hypercalcemia, elevated serum calcium, often indicates metastasis from breast, kidney, lungs. The myths and treatments. Metastasis most common spreads to the lungs, often within 2 years if untreated. Treatment goal: destroy tumor, lymph salvage, and survival. Chemotherapy, multi-agent aggressive therapy to destroy cells, prevent metastasis. We have radiation, of course, used if tumor is radiosensitive or for palliation, pain control. The primary goal of medical management is to destroy or remove the tumor, which can be accomplished through radiation therapy, chemotherapy, and surgical resection. So basically, surgery means the amputation. So for the surgery, we have radical resection, removal of tumor, muscle, bone, and surrounding tissue often requires reconstruction prosthesis. The amputation may be necessary if the tumor is extensive or limb function cannot be saved. We have the nursing management. We use for assessment, pain, assess frequently. Pain is often severe. Neurovascular, monitor for the 5 Ps: pulse, pallor, pain, paresthesia, paralysis. To detect compartment syndrome or vascular compromise. It's very important in musculoskeletal, the 5 Ps: pulse, pallor, pain, paresthesia, paralysis, to detect the compartment syndrome or vascular compromise. Not just for bone cancer, for everything in this unit related to this. Respiratory, monitor for metastasis signs or respiratory depression for high dose opioids. Palpation, so with opioids decrease the respiration rate, so that's why I say the respiratory depression. Palpation, check for mass, size, tenderness, handle gently to prevent the fracture. Nursing action, pain management, administer aggressive analgesic NSAIDs with opioids. Safety, handle the affected limb gently to prevent pathological fracture. Support joint above and below. So this, keep in mind, support joints above and below with this. But this will be more in next chapter about amputation care. Meds, administer chemotherapy, support radiation therapy care. Give emotional and wound care. It's very important here for emotional and also for wound care. Patient teaching, radiation care, avoid creams, lotion, deodorants on the radiation site to prevent burns. Diet, high protein diet for wound healing. Safety, fall prevention strategies due to bone weakness. Medication safety, education on opioid side effects, constipation, drowsiness, and respiratory depression. I'm going to show you a picture. Here it's a picture can be right here. You see the femur and tibia, like another example, but also they say in the humerus, like up here. So it's can be in the big bones, but also in the smaller one, but mostly it's found in bigger bone. Look how big is this? Yeah. So now we go to almost to the end. We are at the end of the chapter. I selected 10 mostly likely high yield quiz question. So I took from all of them like little bit that I felt like popped up that a curiosity, and I felt like, oh, this might be in a quiz or this might be asked. So osteoporosis medication safety. What is the priority teaching instruction for a patient prescribed alendronate, the Fosamax? I say these. I have two medications that always I have in the NCLEX quiz. So answer, take it on the empty stomach and with water and remain upright for at least 30 minutes. Why is asked? The text highlights that specifically under essential teaching points because of the risk of esophageal irritation, esophagitis. So just you can go there and you can see under the teaching. We go next on the post-operative positioning for total hip arthroplasty. Question: what position must be maintained for a patient after a posterior total hip replacement to prevent dislocation? So the answer is use an abduction pillow. I said earlier in the slide to keep legs apart and prevent the internal rotation. Avoid flexing the hip greater than 90 degrees. Is asked because this location is a critical complication. The text emphasizes avoiding crossing legs and using raised toilet seats to maintain these safety parameters. So in this question is very important even for certified nurse assistants. Same, they also learn about how they take caring a patient that have a hip replacement. Osteomyelitis, the gold standard diagnostics. Question: while MRI and blood tests are useful, what is the gold standard test to definitively diagnose osteomyelitis? Or can be bone biopsy, can be like gold standard for osteomyelitis or osteomyelitis diagnostic test. So exam often ask for definitive or gold standard test. The test explicitly states a positive biopsy. It's conclusive for both acute and chronic osteomyelitis. We have 4 Paget disease laboratory findings. Which specific laboratory value is typically elevated in Paget disease, indicating high bone turnover? So the alkaline phosphatase. This is the hallmark biochemical marker for Paget's. The test notes the diagnosis is often incidental when routine labs reveal high alkaline phosphatase with normal calcium. Osteosarcoma, nursing safety priority question. When caring for a patient with suspected or confirmed bone cancer, osteosarcoma, so the bone cancer, right? How should the nurse handle the affected limb? Handle the limb gently and support joint above and below the side. I just said few minutes ago. The text warns that the bone is weakened and prone to pathological fracture, breaking without significant trauma. Scoliosis screening technique. What physical assessment technique is used to screen for scoliosis in adolescents? The Adams forward bend test. It is a standard screening method mentioned. The nurse looks for asymmetry of the ribs, scapula, while the patient bends forward. 7. Total joint replacement. Most lethal complication. What is considered the potentially most lethal complication following a total joint arthroplasty? So the answer is deep vein thrombosis, DVT, leading to pulmonary embolism. The test identifies this is a major mortality risk, reinforcing the need for anticoagulants, warfarin, and early ambulation. Osteomyelitis treatment duration. What is the standard duration and route for antibiotic therapy in treating osteomyelitis? IV antibiotic for 4 to 6 weeks. It's asked because this distinguishes osteomyelitis from minor infection. The long duration and need for peak or central line are key nursing management points. Osteoporosis diagnostic criteria. Question: a T-score of 2.5 or lower on a DEXA scan indicates which condition? Osteoporosis. You need to know the specific numbers 1 to 2 minus, so it's below. Osteopenia, low bone mass. And then after that it's osteoporosis. Muscular dystrophy pathophysiology. Duchenne muscular dystrophy is caused by a genetic mutation that results in the absence of which specific protein? Dystrophin. So it's kind of similar name. Dystrophin, dystrophy. Understanding that the lack of dystrophin prevents muscle repair is the core pathophysiological concept of the disease. So here was like a quick pop quiz summary from this chapter. I hope it make it easier to understand, and I see you in the next one.
We finally made it!
Thank you again for your time and trust. I'm Melania, and from my heart to yours. Until next time, stay zen, stay grounded. Namaste. Bye for now.